Okay, it is 8 o'clock. Good morning, everyone, and welcome to Grand Rounds on behalf of the Department of Pediatrics. I'm Ryan Leon. I'm one of the chief residents. Dr. Leonard, our chair, usually greets us all, is on service this week, so I'm stepping in today. And I'll let Dr. Bondi introduce our speaker, but we always start off with our Stanford University land acknowledgement that Stanford sits on the ancestral land of the Muwekma Ohlone tribe. And if you look on the left side of the screen is the text code for CME credit. Just want to highlight really quickly, we have a wonderful lineup coming up. Next week, we have our own Andres Cardenas joining us from the Department of Epidemiology and Population Health. He's doing incredible work in exploring environmental influences on the human genome. Then the following week, we'll have our Ann T. Bass endowed lectureship in Hem/Onc and stem cell transplant, and we'll welcome Greg Armstrong from St. Jude Children's Research Hospital. He's leading research initiatives on long-term cancer outcomes and survivorship. And then, of course, we need to highlight our 14th annual PEDS research retreat in April 20th, but our abstract deadlines are this weekend, so get your abstract in. It's a wonderful event, wonderful research done by learners as well as our residents. And then a final announcement that the Mid-Coastal California Perinatal Outreach Program is hosting their 42nd annual perinatal potpourri in March, on March 23rd and 24th this spring. We'll cover a lot of topics and will be a very informative webinar. And without further ado, I'll let Dr. Bondi introduce our speaker.
Thank you so much. It's such an honor. And when I looked at the lineup, I'm really excited that one of my faculty, Andreas, will be speaking at the next grand round. So don't miss him. He's a new faculty member in our department, and I think he has a courtesy here in pediatrics. Well, without further ado, I want to introduce our speaker today, who's Dr. Michael Scheurer from Baylor College of Medicine. And I have to take a little credit for his training because he was one of my mentees, and we have continued over the years to collaborate and to work together on different things. But Michael has done an extremely incredible job with building a large pediatric epidemiology program at Baylor College of Medicine. And I have to say that besides that and the St. Jude in the University of Minnesota, he's trained with Dr. Lupo, who spoke yesterday at the Bass Center. So this has been a really great week for cancer epidemiology and survivorship and pediatrics. And so for those of you who missed Dr. Lupo's, I don't think it was recorded, but I know that Dr. Scheurer's is going to be recorded today. So Dr. Scheurer graduated from the University of Alabama. He got his bachelor's degree there and his PhD from the University of Texas School of Public Health. He is a molecular epidemiologist with his major interest of incorporating novel omics data with epidemiologic and population-based studies. And he has done work in both brain and leukemia, brain tumors and leukemias, looking at risk prognosis in both adults and children. We've worked together on several of the adult brain tumor studies. And he has published more than 200 manuscripts, basically in these areas of brain and leukemia and outcomes and risk and omics and survivorship, and all of these types of novel methods to look at these types of data. And today, it's exciting for him to speak, and his talk today is on childhood cancer survivorship among Latinos and where we can close the gap in outcomes. And what he's going to present to you today is one of the new cohorts that he and Dr. Gramaches and others are working on. And I think it is, as you build it, will be a resource for others interested in these types of data. So Michael, thank you so much. And I'm so glad that you're here today.
Perfect. Thank you all for allowing me to be with you this morning. Melissa, thank you so much for the invitation to come and speak. I'm really excited to be here with you all this morning. I want this to really be a conversation because, as Melissa mentioned, we have a new cohort grant through NCI, and the purpose of that is really to build a cohort that can be utilized by others, not just people in our shop. So I want to give you a little bit of a flavor of what that means and the work that we're doing, and have it hopefully be a springboard for ideas that you might have of other projects that you might be able to leverage the data or resources that we're amassing to answer. So a little bit of an outline for our time together this morning. I'm going to give a very brief overview of childhood cancer survivorship. I'm really excited to see that Greg is coming and that you'll get even more of an exposure to the childhood cancer survivorship realm. I think there are some differences about the work that we're doing in childhood cancer survivorship versus what the folks at St. Jude are doing through the Childhood Cancer Survivor Study, and I'll highlight some of those as we go through the talk. I want to give just again a brief overview of some of the key gaps in knowledge about survivorship issues, especially among our Latino survivors, with a couple of snapshots. And again, they're just snapshots. Some of the work that we've been doing over the last few years to begin to address some of these gaps in knowledge. I'll give you an overview of the Salud study, what it is, where it came from, what we're collecting, again, just to give you hopefully an idea of the resources that would be available to answer certain questions. And then I did want to review the Passport for Care, which is a survivorship platform that was developed at Texas Children's in collaboration with the Children's Oncology Group, and how we're starting to leverage the PFC to address some of the gaps and needs among Latino families. So I probably don't have to belabor too much of the next few slides to this group, but just to get us all on the same page, for those of you who may not be as hem-onc oriented, childhood cancer represents only about 1% of all the annual cancer cases that occur in the United States. And while mortality has decreased over the last several decades, we have seen an overall increase in incidence during that same time period among all childhood cancers. We'd love to understand more about why that is, but until we understand what causes a lot of childhood cancer, we won't really understand what's contributing to the increase in incidence. And that decrease in mortality obviously equates to an increase in survival. So we've seen a dramatic increase in survival among childhood cancer survivors over the last 50 years. The average 5-year survival rate now is around 86%. It's obviously a little higher than that for some of our cancers and a little lower than that for others. And that equates to somewhere in the range of about more than 500,000 survivors of childhood cancers living in the United States today. And what that means is that about 1 in 530 young adults, so those who are currently aged 20 to 39 years old, is a survivor of childhood cancer. Now, again, we said survival is not really equal for all children who develop cancer. You can see the top left graph there shows this 5-year survival rate for children and adolescents for the different pediatric cancers, Hodgkin disease, ALL, NHL among some of the highest 5-year survival rates, AML, brain tumors, some of the more rare soft tissue sarcomas, obviously a little worse survival. Other things that we've noticed, though, is that individuals or families who self-report as Latino also have worse survival compared to those who are self-reported non-Latino whites. And if we dig a little bit further into social determinants of health, you can see by that graph on the far right there, those who live in areas that are most disadvantaged have the worst survival compared to those who live in areas that are least disadvantaged. So we really need to take a step back and look at the cumulative effects of all of the factors that might be contributing to poor survival, as well as the factors that might contribute to the varying incidence of late effects among our childhood cancer survivors. So let's talk about those chronic health conditions. And this is where I think giving a talk to the broader pediatrics department is always interesting, because many of you probably deal with some of our survivors as they age through childhood into adolescence in dealing with some of the chronic health conditions that are a result of usually the treatment that they receive for their cancer. So we can see that radiation can contribute to growth hormone deficiencies. If radiation to the brain is given, we know that radiation and our certain types of radiation, as well as certain types of chemotherapy, can lead to cognitive deficits that really get worse as the child ages into adulthood and goes on into their adult life. There are a number of psychosocial issues that they deal with, which impact ability to function in daily life, to hold down jobs and have meaningful experiences as adults as they move forward, and so forth and so on. There really isn't a system that isn't affected by in one of the childhood cancer groups as they move forward. And not surprisingly to us, actually, but maybe surprisingly to some people, work out of the childhood cancer survivor study with the folks at St. Jude shows us kind of what the incidence of these late effects looks like. So if we look at the severity of these late effects, grade 1 through 5, upwards of 80-ish% of survivors will have at least one late effect from their treatment by the time they reach 30 years out from their diagnosis. And you can see that that varies from tumor type to tumor type. So the leukemias, the CNS tumors, the soft tissue sarcomas, and some of the other bone tumors are shown in these particular graphs. But you can see both that overall, any grade 1 through 5 of these adverse outcomes, as well as the more serious grade 3 and then life-threatening grade 4 and fatal grade 5 ones are really very highly prevalent among the various pediatric tumor survivors. Now, one thing that's really cool about the way the CCSS is set up, and Greg will talk about that in a couple of weeks when he's here, their comparison group are the unaffected siblings of the children who've been treated and enrolled into the cohort. So all of the effect estimates that we see here for the varying late effects are in reference to the unaffected siblings. So we can see that for any grade 1 through 4 type of late effect for all cancers combined, you've got over a 3-fold increased risk of developing chronic health conditions, and an 8-fold for developing severe or life-threatening. And you can see that our brain tumor survivors, as well as those with other central nervous system tumors, have even higher risks than the overall groups. And furthermore, in that far right column, you can see that it's not just one health effect usually that these people are dealing with as they age into adulthood. Most of them have 2 or more chronic health conditions that they're dealing with over their lifetime. And then here, this particular slide, again, results from that New England Journal paper medicine from the CCSS, shows the conditions themselves that are more common among our survivors. Joint replacement, congestive heart failure, second neoplasms, cognitive dysfunction, coronary artery disease, at a 10-fold or higher risk in our survivors compared to their unaffected siblings. And so this just highlights again the serious nature of types of effects that these patients deal with as they age away from their cancer treatment. Now, I probably don't have to tell this group much about this in particular, but Latinos have now become the largest racial ethnic subgroup in the state of Texas. I'm sure if they're, haven't looked at California, but if they're not already, they probably will be here as well. And that happened in Texas. They made the crossover in 2022 or 2021, and the projections show that they will far outpace other groups in the state. And also, not surprisingly, is especially in the southwestern corner of the United States, Latino children make up a large proportion of the pediatric cancer cases that are occurring in these states. And you can see, based on the SEER data, the proportions that are in each of those states. We also know that our Latino children experience poor cancer outcomes, so that especially those with acute leukemia are nearly twice as likely to relapse compared to non-Latino white patients. In the CCSS, again, both African-American and Latino survivors have a higher prevalence of obesity and hypertension than their white counterparts. And Latino pediatric cancer survivors are more likely to report later in life lower socioeconomic status, both lower income, lower educational attainment, and health insurance coverage as they age into adulthood. So some of the knowledge gaps that we think exist, there is definitely a gap in the comprehensive assessment of the contributions of demographic, socio-cultural, environmental, genetic, and other molecular factors that influence these outcome disparities that we observe, that you all observe in your clinics. There's also a gap in our understanding of the extent to which socioeconomic disadvantage drives differences in these outcome disparities between different groups. And there really are studies that have been conducted to date have been limited by a low proportion of non-white participants. Now, we do know that overall incidence for childhood cancers, for many childhood cancers, is higher in non-Latino white populations, sort of mid-level for Latinos as a group, and then much lower incidence for African American and Asian American children. But very few studies have really been able to include some of these non-white groups, and that's what we are really striving to do being in Texas. Furthermore, very few of the studies that have been conducted to date are describing the neurocognitive and psychosocial behavioral outcomes and the health-related quality of life that's perceived by the survivors and their families. And it's one of the things, again, that we are striving to do with our work. Okay, so with that sort of background, I want to walk through just a couple of really short examples of some of the work that we've been doing, much of which has been driven by observations from our clinical partners on these studies. And the first one is looking at methotrexate-related neurotoxicity. So methotrexate, as many of you probably know, is a backbone chemotherapeutic agent, especially for leukemia protocols and ALL in particular. And ALL is the one of the few pediatric cancers where the incidence is actually highest among Latinos. This is an important problem that we really need to try to understand. So you can see from the cumulative hazard plot on the right side here that the cumulative incidence or the cumulative hazard of methotrexate-related neurotoxicity is much higher among our Latino patients. So these are data from Texas Children's Hospital compared to our non-Latino white patients. And one of the things that we notice is that not only is the hazard much higher in that group, but it kind of accelerates much more quickly among our Latino patients compared to the non-Latino white patients. So in comparison, there's about a 2.5 fold increased risk of the development of neurotoxicity at some point during ALL therapy among patients. And what this does is neurotoxicity often results in either holding therapy or delaying therapy. And when we looked at the average number of doses of methotrexate, in particular intrathecal methotrexate that was provided, those who experienced a neurotoxic event received on average about 2.25 fewer doses of methotrexate because of their neurotoxicity. And when we looked at outcomes related to experiencing neurotoxicity, we also saw that those who experienced neurotoxicity were more likely to relapse compared to those who didn't. So we had a 10.3% relapse rate among those who experienced neurotoxicity compared to only a 2.1% relapse rate among not experience any neurotoxic event. So if we looked at some of the clinical and demographic characteristics related to toxicity development, we saw a few things. One, the patients who developed neurotoxicity tend to be a little bit older than those who didn't. There was definitely a racial or ethnic composition. So about 75% of the patients who developed a neurotoxic event in our clinical cohort were self-described Latino compared to only 55% of those who did not develop a neurotoxic event. Probably not surprising if you were a high or very high risk leukemia patient, indicating a more intense chemotherapeutic regimen, you were more likely to develop a neurotoxic compared to those who were more standard risk disease. We didn't really see a difference per se in B versus T ALL or if it was lymphoblastic lymphoma. And we didn't see in this group a specific or a significant p-value associated with relapse and or death. But again, you can see that relapse or death was about 18% in the neurotox group compared to only 8% among the no neurotox group. Now, one thing that we wanted to look at beyond just sort of having a first neurotoxic event, because we were noticing that especially our Latino patients who experienced one event were more likely to experience 2 or 3. We had one patient who even experienced 4 neurotoxic events over the course of their methotrexate chemotherapy. And again, in this regard, we didn't see necessarily a difference in the age at diagnosis for those who only had one event versus those who went on to have 2 or more events. We didn't necessarily see a sex difference between those. The race ethnicity difference isn't statistically significant, but again, 87% of the patients who developed a second event were Latino compared to non-Latino white group. We did not see necessarily a difference now in the disease risk category. And again, we did not see a difference based on diagnosis. There was a difference in mean time to intrathecal methotrexate rechallenge, though. So we saw that those who only had a single event had a much longer period of time between their first event happening and the reintroduction of their methotrexate versus those who had a second event maybe were rechallenged a little too soon and hadn't had a chance to fully recover from the first event. And then we did not, again, see a difference, necessarily statistically significant one in relapse or death based on second events, but you can see that 33% of those who developed a second event relapsed or died compared to only 15% group had a single event. So we're trying to understand the factors beyond clinical and demographic factors that might be contributing to this. So we had some genetic data from a genome-wide association array that we had conducted, and we looked at genetic ancestry related to neurotoxicity. The group out of St. Jude has looked at the incidence of relapse among patients who have higher proportions of Native American ancestry in their genome and have found that higher proportions of Native American ancestry seem to correlate with increased risk of relapse. So we thought we would look at this for neurotoxicity, and indeed we found that for every 10% increase in the proportion of Native American genetic ancestry, you had a corresponding 16% increase in neurotoxicity incidence. And this was even after accounting for the other factors that we had already found to be associated, such as age, sex, or the treatment risk group. The other thing that we've been interested in looking at in sort of relation to this is cognitive complications of CNS-directed chemotherapy in ALL. So again, pediatric patients over time have reported frequent impairment of attention, memory, processing speed, and other neurocognitive measurements. And again, methotrexate in this case is the suspected agent that might be contributing to these decrease in cognitive function, mostly again related to the IT or intrathecal methotrexate, as well as some of the high dose IV methotrexate that these kids receive for a very long time throughout their treatment. And because of the intrathecal method of delivery for the methotrexate, CSF is a very attractive biomarker that we can use for some of the discovery that we're trying to do. Number one, it's available because it has to be removed in order to give the methotrexate. Otherwise, it would just basically be tossed away. And we think it to be more of a biologically relevant matrix for biomarker discovery when looking at CNS effects of the CNS-directed chemotherapy. So these data that I'm going to share with you are from a little older study that we conducted at Texas Children's, University of Arizona, and the University of Minnesota. And we had a prospective study of 96 ALL patients. They were diagnosed between 2012 and 2015. And we had given a 43-item caregiver-completed pediatric performance scale to the parents over the course of treatment. So you can see from the figure, the arrows indicated with the little head there at the end of induction, the beginning of interim maintenance 1, the end of interim maintenance 2, and then the beginning of maintenance 2. This caregiver scale was administered. And we used CSF that was collected at the start of DI for our biomarker discovery. And the first thing that we did is that we looked at cognitive decline over the course of ALL therapy among this group, and we used a latent class growth mixture model to identify 3 classes within just the neurocognitive data. So the first group, that group 1 in red at the very top, had a consistently high level of neurocognitive functioning over the course of their therapy, and that represented about 73% of the patients that were included in the study. Group 2, the one in blue there in the middle, had some modest declines over therapy, and that represented about 23% of the population. And then we had a small group, about 4% of our patients in group 3 in the green there at the bottom, who experienced some profound early decline and sustained low level of neurocognitive functioning over the course of their therapy. So we used these data as an outcome to do some of our some of our biomarker discovery. So we used group 1, that high level functioning group, as our referent group, and then we combined groups 2 and 3 as sort of our group with neurocognitive decline we're interested in finding some biomarkers for. So we took the CSF, we sent it off to Metabolon, and we did some untargeted metabolomics analysis. Metabolon was able to identify a total of 314 biochemicals in the CSF samples that we sent them. And you can see from the volcano plot on the left that there were 6 of the metabolites in particular in the red that were significantly skewed in our group 2, group 3 patients compared to the group 1 patient. And if we look at both the levels of those from the box whisker plots, as well as the pathway, we can see that there were very particular pathways of biomarkers that came up. So interestingly, all 6 of the candidate pathways from the volcano, or candidate metabolites from the volcano plot that we identified in this one, had been linked to both neurocognitive and neurological disorders in adult populations, but they had not been implicated in treatment-related cognitive impairment, neither in adults nor necessarily in a pediatric group. So after accounting for multiple comparisons, there were significant alterations that we identified in several pathways, and 4 of 6 of the metabolites were in pathways either upstream or downstream of dopamine, suggesting that perhaps ALL treatment may disrupt neurotransmitter pathways that might be necessary for normal cognitive function. So the relative abundance of each of these metabolites was significantly lower in the individuals with symptoms of cognitive impairment, while there was an additional metabolite, the 3-MT, you can see in the light pink in the graph, was borderline significant. So all of the ones that were in gray were not necessarily significantly different between the two, but you can definitely see a relationship with this pathway, particular pathway, being formed from these data. So the next thing we wanted to do was say, okay, can we use this data to try to predict individuals who might be at highest risk for developing neurocognitive decline early on, so before they even start getting therapy? So symptoms of cognitive impairment, again, are common during ALL therapy, and we had already identified some clinical and demographic factors that might contribute to a risk prediction model. So if we take that information, we can see the ROC curve on the right. The blue line indicates those clinical and demographic factors. We don't do bad. The area under the curve is about 71%, so that's not terrible. But if we add those metabolites into our prediction model, we do much better with predicting individuals who are likely to develop neurocognitive decline versus those who won't, with an area under the curve now 89%. So the information from the molecular data that we're able to add into that clinical predictive model really increases our ability to predict who might be at risk for the development of neurocognitive decline. So we view this as, CSF metabolomics may help identify these high-risk patients, and we're looking now to expand our cohort, do more biomarker discovery, and do some follow-up work from this initial work. All right, so that really led us to the opportunity that we had to develop the SALUDE study. So SALUDE stands for Survivorship and Access to Care for Latinos to Understand and Address Disparities. And our overarching objective is to identify and comprehensively assess adverse outcomes in a diverse cohort of pediatric and adolescent cancer survivors, which hasn't really been the case for many of the other cohorts that exist. And what we hope is that this particular cohort will lay the foundation for early targeted interventions to mitigate the outcomes, some of which we've been talking about. There are many others that could be looked at in the vulnerable and growing Latino survivor population. So this particular mechanism, I don't know if you're familiar with it or not, it's in two phases. So there's a UG3 phase, which we're wrapping up right now. It's meant to really ramp up the assembly of your cohort. And so the aims of the UG3 phase were to assemble a prospective cohort of pediatric cancer survivors, a total final sample size of about 3,500, with 50% of those being self-reported Latinos. And we're leveraging our network of pediatric cancer treatment centers across the state of Texas to really get to this final sample size of 3,500. We're collecting sociodemographic, clinical pathological, neurocognitive, and behavioral data, as well as patient-reported symptoms and quality of life outcomes from the survivors in the cohort during this phase of survivorship. We're also collecting a number of different serial biospecimens, so saliva, buccal cells, blood samples, CSF. We added urine, and where available, if the tumor is available, we like to at least know that we have access to the tumor. We can start looking at somatic things that are happening in the tumor that might be contributing to survivorship as well. And all of these samples can be then used for genomic, metabolomic, proteomic, omic of your current flavor use over time. The UH3 phase, we are submitting our transition plan to NCI sometime within the next month. So the UH3 phase, we hope, will begin at the beginning of May of this year. And this is where we get to really start doing some fun science. So the UG3 phase last 2 years, it was really limited budget, only focused on continuing or starting collection of samples and data from our survivors. The UH3 phase, we basically double our budget and we're able to start doing some really cool science over the next 4 years. So the scientific aims in the UH3 phase are to identify demographic, clinical, genetic, and molecular determinants of treatment-related toxicities and their association with chronic health conditions later in life, as well as patient-reported symptoms and other patient-reported outcomes, again, in our diverse cohort of survivors. Identify the same types of factors that might drive an excess risk of relapse or recurrence, especially among Latino patients in the survivorship era. And then finally, to determine the survivor's understanding of the risk for late effects and the rationale for attending or not attending their recommended survivorship care plan, and to identify any perceived facilitators or barriers to obtaining appropriate survivorship care and factors that might be affecting lost follow-up. So there are a number of things that other colleagues of mine at Texas Children's have been interested in trying to understand. Why are we losing so many of our survivors? Why are they not coming for long-term survivorship care? What are the factors that we can potentially address with them to help increase their uptake of survivorship care? So the first two aims, a little bit more molecularly oriented, but really that last aim, much more clinically oriented, trying to understand why aren't people doing the things that we really ask them to do to try to mitigate some of these. So again, our population reaches throughout the state of Texas. So I've got here a list of the sites that are included in a core facility grant that I have from our state Cancer Prevention and Research Institute. And 5 of those 7 sites that are included in access form the backbone for the SALUDE study. All cancer diagnoses are eligible. Again, our final sample size is to try to reach 3,500. We've got, with the goal of 1,000 of those survivors already having been enrolled in the access core facility protocol, and then an additional 2,500 survivors who were newly diagnosed since we started the SALUDE study. So we're leveraging an accelerated longitudinal cohort design for SALUDE because we have the opportunity to build from access. If we look at the timeline across the bottom of this particular graph, you can see it's months since diagnosis. So we try to enroll everyone around the time of diagnosis or almost immediately after collecting an inordinate amount of data, biospecimens from them. And I think this is where I'd like to point out where we're a little bit different from what the CCSS is doing and has done in the past. So we're able to look at that early and intermediate phases of survivorship, whereas the way the Childhood Cancer Survivor Study was founded, they only include patients who reach the late phase of survivorship. So they have to be 5 years or more out from their treatment and able to be enrolled in that particular cohort. So they're really good at looking at a lot of late effects. They have a lot of really older adult survivors of pediatric tumors. We are able to look at more of the intermediate, early and intermediate phase. So treatment-related toxicities that are happening during or immediately after therapy is initiated or ended. So again, with the access or building from access, we have the full spectrum, and then the Salute cohort for most of our patients will really get us through sort of that intermediate phase, but we're hoping to continue collecting data and sample these survivors for as long as we can have funding to do so. The biospecimens that were collected, again, I went over that a little bit earlier, but you can see the particular biospecimens that we are collecting, the potential uses for those, and then the timeline. So again, we're trying to collect, as hard as it may be, especially at diagnosis, we're trying to get an at diagnosis sample for many of these. There are a couple of time points, and this varies from tumor to tumor because the treatment timeline differs by tumor type, but we have a couple of time points that are during therapy. We're trying to get one at the end of therapy. So whatever that looks like for our leukemia patients, that's obviously a little longer, 2 to 3 years. For some of the other kiddos, it's only about a year or so. And then once they hit late effects survivorship clinic, and then annually after, we want to track what's happening with them over time. And I think this particular graphic just kind of highlights some of the success stories that we have of using different omics platforms in discovery for some of the late effects that are happening among our cancer survivors. So you can see by particular system on the right, what we've learned and what we know about which agents or therapeutic regimens are actually contributing to some of these adverse health effects. And there have been some success stories. So we know that cisplatin therapy can lead to ototoxicity among certain patients. And there's a variant in the ACYP2 gene that's been identified that might put those particularly at risk for sensitivity to cisplatin ototoxicity. NUD-T15 has been identified, or variants in NUD-T15 associated with thiopurine toxicities, especially among our leukemia patients. And a lot of the rationale for using these omic technologies is that for many of these late effects, we know what the causative agents are. We just don't know the molecular pathways by which they may be contributing to these particular outcomes. So if we can use different types of omics to identify high-risk patients, we can then or possibly deliver targeted interventions to prevent them from developing these. And again, I go back to the ototoxicity example because there are some chemoprotective agents that we can now give to patients who are receiving platinum therapies that might offset the risk of developing ototoxicity. So next few slides kind of go over some of the data that we're collecting. So NCI kind of in the RFA that they submitted for these UG3 cohorts, they kind of said, we want you to collect data in 5 different domains. One, disease characteristics. So we're collecting data on cancer type. We're collecting, when available or appropriate, cytogenetic or other molecular markers that are already sort of routinely collected or characterized for different pediatric cancers. And I mentioned earlier, again, we are collecting information at least on the availability of tumor tissue. So if we wanted to go back and do any other tumor markers later, we might be able to. They wanted you to collect information on the individual survivors' characteristics themselves. So what is their socioeconomic status or position? What's the level of acculturation, which we felt particularly important for our cohort? What are the other comorbid conditions that they're experiencing? What is their information-seeking behavior, and what do they feel or know about their access to particular care? And in this case, we're interested in survivorship care. What are some of the treatment-related characteristics? So what are the different chemotherapeutic, radiation, or surgery related treatments that they've received, the chemos and the radiation? What are the doses of those that they received? Have they experienced any treatment-related toxicity? So neurotoxicity we're really interested in within our group. And then what is their likelihood for follow-up care? What are the behavioral or lifestyle factors? We had some really cool stuff built into the cohort early on to be able to track physical activity. We were going to buy everybody a Fitbit and send it home with them and track a lot of information, but budgetary cuts had to remove that. But we do have some questions on sort of routine physical activity. Diet's always a tricky one, but it's sort of an important one, especially for some of our childhood cancer patients as they're going through treatment. A lot of times their diet is not great because you just want them to eat something, anything, and keep it down, right? So, and then they form some habits of unhealthy eating that might, carry them forward after their treatment diagnosis. What are their adherence to therapy? So we don't have I think there are some pediatric cancers where we do have adherence to therapy issues, but I think adherence to the follow-up guidelines is more of an issue for our survivors. And then finally, they wanted a lot of information on quality of life and some of the other patient-reported outcomes, which is not something that we had initially been collecting through our Access core facility group, but we engaged Lisa Cahaley, one of our really talented neuropsychologists, and Lisa's really leading the charge on this. So we've got patient-reported outcomes in symptoms and toxicities, self-reported chronic health conditions, and then she's really including a really huge and comprehensive battery of neurocognitive, psychosocial, and functional outcomes that she's including as well. So all of these data will be available to really mine and look at as we move forward. Again, just a brief overview for both the demographics and the patient-reported outcomes. We have particular time points that we're trying to target. We like for them to align at the time points where we're also collecting samples so that we can correlate what's going on molecularly or genetically in some of the samples with the patient-reported and other treatment outcomes that we have. I'm not going to go into this too much. Just a couple things I wanted to point out about some of the PRO measures. I don't know how many of you have kind of worked with these in the past, but they are quite comprehensive, but there are some problems with using them. Number one, especially if people aren't coming back to the clinic, it can be hard to do some of these things in person. So we've tried to move as much of our patient-reported outcome, including the neurocognitive assessments that we're doing, to be online. So we're utilizing a computerized neurocognitive battery that Lisa and her team have used in the past. We can do remotely with patients rather than having to come in. And I think starting all of this during the middle of the pandemic, that was also a really important aspect of what we wanted to build out. So we're hoping that will actually eventually increase our ability to get this information from our survivors. And further complicating the matter is that there are varying versions of these different measures depending on the age of the person who's completing it. Obviously, if it's a child and especially younger children, a lot of these are being completed by the parents, not by the child itself, but as they age into adolescence and in early adulthood, they'll be completing them themselves. So you have to think about the complexity of how many versions of different instruments are you going to have to dole out, and who gets the email to complete them versus not. So it's not a trivial task for sure. And then related to factors associated with adherence to therapy or adherence to follow-up care, we know that there are a few predisposing factors. Some of those are clinical. So we know the treatment associated with different cancer diagnoses are different. And have different intensities. They last longer for certain groups than they do for others. There are some demographic factors, so age at diagnosis, race, ethnicity, gender, socioeconomic status or place. And again, we think that there are some potentially intervening factors that we can assess and then hopefully provide some interventions to address. So there's some survivor level factors. So their health self-efficacy, so how they feel about being able to take care of their own health. Depressive symptoms, which we've learned actually are higher among our children who are even just going through therapy. So we've noticed in our group that depression is a huge problem for our patients. Family level factors. So, a childhood cancer diagnosis does not just affect the patient, it affects the entire family. We know financial toxicity is a huge problem for many of our families. And these are things that we hope we'll be able to address in some way moving forward. And then there are some system level factors. So, how are things in the hospital? Do you have, particularly for our Latino patients, are there bilingual providers, and how comfortable are the providers in providing care in a bilingual setting? What is the health insurance status? And this working through, is there a regular healthcare source for individuals outside of their oncology care? And again, the two measures that we're trying to look at as outcomes here are adherence to therapy and then intent for follow-up care. So we've done a little bit of work in the last few minutes we've done a little bit of work starting to look at facilities and barriers to survivorship care, because we were able to leverage that earlier cohort that we had already established. We developed a 56-item bilingual survey that's being administered to all of our survivors annually. And that way we can track their responses over time to see if anything's changing through just increased knowledge or experience with the system. And this questionnaire really queries multiple domains, including health behaviors, health status, self-perceptions, perceived late effects risks. So many of the families just don't understand what those late effect risks are, and really the importance of survivorship care, social and financial barriers to accessing survivorship care, and so forth. We did a brief analysis of these data early last fall, and there were 150 respondents to the survey at that time. And we're still in process and planning to do some additional interim analyses early this spring as the data are a little bit more complete. We also developed a 25-item, again, bilingual survey that's just administered once. And we did this early on in the UG3, so between November 21st, 2021 and March or earlier of 2022. We gave it to both the survivors and the caregivers. And it really asked how they wanted to access information, what their preferences were for how to receive information about survivorship care, and to gather some information on preferences and educational needs. Like, what do they want to learn about in terms of survivorship? So we had 135 responses. 56 of those were from survivors themselves, and 79 were from the parents of survivors. And these were conducted at 3 different of the Salud sites that were included in the map that I showed you earlier. And there were really some interesting findings that we had from this initial survey about education and survivorship. So both survivors and parents selected risk for second cancers and diet, nutrition, and exercise as their highest educational priorities from a predefined list that we had. And there really was no difference based on ethnicity of the participants. The parents, however, were more likely than the survivors themselves to seek information about survivorship from other survivors or from families who had a childhood cancer survivor. So they were 8 times more likely to want to talk to other families or survivors to gather their information. And they were also more likely to utilize social networks comprised of survivors or families, about 3-fold more compared to the survivors themselves. On the other hand, survivors, TikTok era, right, wanted short videos as a mode of learning their information. So they were about 2.5 times more likely to prefer these short videos. Interestingly, non-Latinos were more likely than Latinos to prefer social media as an educational source, about almost 4-fold. So we're using this information to try to develop the short educational videos, both in English and Spanish, to address the needs that were identified from the survey. And in conjunction with the video content being developed for a couple of the other grants that were received from CPRIT, our state funding agency, to expand the utilization of the passport for care. And again, you can see a list of some of the topics that we're developing there. And these videos are about 2 to 3 minutes. They're conversational. They're in English and Spanish, and they'll be made available through the Passport for Care Survivor website. So just a reminder, I asked Monica, who sort of oversees the research part of the Passport for Care, if you guys were using the passport, and she said yes, so that's fantastic. But for those of you who may not be familiar, the Passport for Care is a clinical decision support tool that generates a personalized survivorship care plan. So Institute of Medicine said a long time ago that we need to be providing a summary of the cancer treatment that all of our cancer patients are getting, and we need to be able to provide them a survivorship care plan. Now, the Children's Oncology Group and the long-term follow-up guidelines for survivors have been developed and honed over many, many years. But it's a document that if you printed it out would be, yay thick. So the really great thing about the Passport for Care is you enter the treatment information about the patient into the system, and it generates those guidelines for you. You're not having to look up individually. And it, again, provides the treatment summary, the risk for late effects based on the treatment exposures that particular child had, as well as the recommended surveillance for late effects and health outcomes. So originally it was developed as a clinician tool, and that's where the clinics go in, they enter all the treatment information, they can provide the care plan. But over time, they've also developed the survivor website to complement that. So now the survivors and their designated caregivers can actually log into the system, and they can look at this information themselves. They can print out a PDF of that. They can take to their PCP and be able to provide information from the guidelines to their normal provider on what that is. So again, it offers survivors and their families access to the clinic-generated personalized care plan, allows survivors and their families to share that care plan with their PCP or any other specialist that they might be seeing. The content, excuse me, is in both English and Spanish, including full translations of all the documents. And it provides access to resources supporting the survivors, including this suite of new videos that we're developing to integrate into the system. Now, one thing that Monica has really taken the lead on is developing the Passport for Care completely in Spanish, developing new content that is in response to the results that we've gotten back from our Latino families, and providing them the information that they want in a mechanism that they want to see it and in their preferred language. So using some new funding from CPRIT, as well as some funding that we built into the Salud grant, we're updating all of the content across the entire site, including the new videos. And the screenshot on the left is Monica. So Monica's a Cuban heritage, and she speaks Spanish fluently, and she really takes the lead in providing a lot of the Spanish language content to our survivors. And she's overseen the translation of the entire website into Spanish, so that everything is familiar and can be accessed as it's and then finally, there are a couple things I wanted to share with you, also with some new funding from CPRIT. We're developing an mHealth app for the Passport for Care. It will be available in both English and Spanish, but again, it offers survivors and their families on-the-go access to their survivor care plan, which you can see a screenshot of here, which you can dig down into the types and amounts of therapies that were received. It offers the capability for them to view a listing of their potential late effects based on their treatment experiences. There's a notification component to it. So if new information is added, you can do that. It provides then for each of those, you can dig into the health links that are available, both in English and Spanish, on each of these late effects. And there's a chat feature that they're building in that allow the survivors and their families, first and foremost, to interact with clinic staff who want to use the chat function, but also potentially over time add in a capability of interacting with other survivors and caregivers through the app as well. So with that, I first of all thank you all for the opportunity to be here with you this morning. This work is huge. It couldn't be done. Again, we always say this, without a village, both village in terms of people across these different sites we've collaborated with over time, as well as the amount of funding that we've been fortunate to give to drive this research. So again, thank you all, and I'm happy to answer questions.
Oh, online, but
Yep.
No. Question?
Yeah, so we're approaching that from a couple of different angles. One, we've built in questions into our various questionnaires that address these factors. We're also utilizing place-based methods, GIS, and other related information to get census tract level information on a lot of the social determinants. So we're trying to take a slightly more comprehensive approach, and we hope that we'll be able to gather the data that we need to address those confounding factors. Yeah. For the neurotoxicity, yeah. So neurotoxicity, for the retrospective part that we've done so far, it's been based on whether or not whether or not a brain MRI was requested, because again, we're trying to leverage the EHR data for that. So we do that first, and then we go into the record and we look to see, you know, what was happening with the patient around the time of the MRI. Going forward prospectively, that's a little bit more complicated. Again, we're looking for stroke-like symptoms. We're looking for other things that would be classically neurotoxic event, not PRES or some other presentation that could be, you know, potentially confused for that. So I'd love to talk to you about that more, because
I find like the calcium deposition. How to define.
We have a current project now. So Philip and I and others, we have a spore planning grant right now that we're hoping to transition to a full spore. In that, there is a project focused on neurotoxicity, and we're trying to include more novel imaging technologies so that we can leverage some of the imaging to hopefully tease apart, you know, these other issues related to the neurotoxicity.
Question on
So will you be assessing environmental factors for the Latino and other children, for example, exposure to pesticides or other environmental chemicals? Excellent question. Yes. And again, we're doing this in a multi-pronged approach. So one, we're able to do that through the questionnaires that we have each of them answer. We're also doing that based on area-based GIS methods that exist for looking at pesticide and other environmental exposures. And then a third way that we're trying to leverage that is using biomarkers in a number of different ways, because we know self-report and even the area-based methods for determining the environmental exposure aren't always the best. So we're trying to do in many different ways, and hopefully what we can do is leverage the information that we gain from that to validate self-report or by questionnaire or the GIS methods. Excellent question. Yes.
I just had a question about your metabolomics data. I was just wondering if you had a chance to stratify the data based on like the ethnic backgrounds, and have you seen an overrepresentation of those metabolites you spoke about in Latino, and have you actually made any correlations to genetic data as well?
So excellent questions. And we haven't done that yet, but we are doing it currently. So I don't have any results to share yet the data that I showed, again, was based on about 100 patients. Since then, we've been collecting the samples. We have funding through a few different funding streams, including some additional money in Salud to send off for additional metabolomics. Everyone's being genotyped across the cohort as well. So we will have the genetic data soon that we can both correlate with the metabolites themselves, as well as genetic ancestry in the metabolites, and then in a much larger group, because once we start subdividing, our sample size needs to go up to accommodate. Excellent question, though.
I was curious looking, at your data on methotrexate neurotoxicity and just seeing how much it could potentially impact survival and how variable COG's recommendations are for how to kind of manage it. If you have thoughts either on standardizing an approach or kind of investigating, like where are you going to go from there in terms of
that? Excellent question again. And for the full spore application that we're trying to develop, again, there will be a neurotoxicity focused project. And one of the things that we're going to try to build into that is probably a genetic risk prediction model. And then hopefully those who are at highest risk based on the genetic information can be either followed more closely or have an altered dosing regimen. So I think that's obviously going to have to be led by my clinical partners on these projects, but we are trying to think of ways that we can standardize and do that. So they've been able to do that, again, like with the NUD-T15 variant, some of the other variants that have been specifically related to pharmaco exposures. So we hope we'll be able to get to the point of doing that with the neurotoxicity.
Any other online?
One more here, yeah. Do you have issues with skeptical parents, patients about the value of your follow-up to them? That's an excellent question. We haven't had that yet. We actually find that most of our patients and families are really interested in contributing to these projects. They really want to know what's going on. I think that could be potentially a problem, especially for some of our Latino families who may be undocumented. Like some of them don't want to provide income information, or they don't want to provide address information. But a lot of the other data that we're trying to collect, there really have been no problems collecting. And then we had one more. In addition to genetic markers, are you collecting any parental prenatal DOHAD data? Okay. So the questionnaire that we have definitely collects a lot of data from the parental side and the perinatal side. We also, through some collaborations that we have in relation to the other question earlier about environmental factors, we're looking for ways to utilize deciduous primary teeth in measuring exposures that may have happened during fetal development and early in childhood. So we're really trying to investigate other ways, like I said earlier, of using biomarkers for measuring some of these exposures rather than relying on self-report.
All right. Thank you so much. We're at the hour, and I want to thank you for coming and presenting a phenomenal lecture. And I'm just totally floored by all of the data that you'll have and the opportunities for research. So thank you, everybody who came. It was a bigger crowd than I expected, and there was a lot of people online. So thanks so much for being here today.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.